So I'm going to talk about the dosimetry in pregnant patient undergoing both CT and fluoroscopy. This is a shorter talk of the other two in terms of the time frame we are using. The reason why we need to understand some of the radiation effects on pregnancy is because currently this publication published back in 1989, nearly 30% of all trauma patients are females in childbearing age, and nearly 15% of female trauma victims may be pregnant at the time injury. Like most of you know, that's where we get the calls from the emergency room where they have already done the imaging to save the patient, where the benefits far outweighs the risk. At that time, we are retrospectively asked to calculate the fetal dose. And that's where this particular talk is focused towards how we can assess these things in some of the information we already have. Probably many of you also have seen this slide and have used this in your teaching your residents, because the radiation effects on the unborn can be categorized understood in different ways. One is, as most of you know, the most sensitive part of the pregnancy is during the first trimester of the pregnancy. That is, during 2 to 15 weeks post-conception is considered the most sensitive part of the pregnancy for any type of effects. In terms of the radiation effects, in this particular chart, which is published in Eric Hall's book, the human equivalent pregnancies seem to be equivalent to mapped quite nicely on the mouse model. And this mouse model, the effect on the mouse effect is shown based on the irradiation of more than 200 rats given to these mouses at various stages of the pregnancy. And they have described here the effects on this pregnancy. So based on this particular chart, you can see if the radiation exposure to the fetus occurs during the first trimester, a large radiation dose, I'll tell you what the dose levels are, the primary effect is predominantly is more of prenatal or embryonic death or spontaneous abortion. That's the high probability occurrence during the first trimester if the dose is very high. However, as the pregnancy matures, if the radiation exposure is during the latter part of the pregnancy, during the second or third trimester, the spontaneous abortion or prenatal death probability will decrease as shown here, but the other probability will increase, such as abnormalities, neonatal death, increase in leukemia, and so forth. From the understanding what we have from studying the Hiroshima and Nagasaki population and so forth, there have been demonstrated that the radiation exposure during the later part of the pregnancy has shown some of these children with decreasing head size and increasing in mental retardation and so forth. Gross congenital malformation is another effect of the radiation exposure to the pregnancy. Generally, this is the ballpark number we use. The increased risk of childhood cancer is estimated to be about 10 milligray, or 1 rat fetal exposure during the first trimester would have an increase about 35 times. Again, these are not H number, but these are the ballpark numbers which we normally use for trying to understand the effect of radiation effects on the pregnancy. If I stop here and say this is what the effect on the pregnancy, but the rule of thumb which we physicists we normally use is, here's a picture of this atomic bomb survivor irradiated in utero, which has this decreasing head size and so forth. So the rule of thumb is like the radiation effects on the patient, especially if the dose of more than 100 milligray or 10 rad during the first 6 weeks after conception is generally considered as a cutoff point above which therapeutic abortion is considered. And this has been the rule of thumb we have been using for understanding some of these effects. So if a patient underwent a lot of imaging procedure and we estimate the fetal dosimetry to be around more than 100 milligray, that's when it's considered as a point for us to recommend for some type of therapeutic abortion. Again, it's a recommended, and that's then left to the physician and the patient to make the determination of termination of the pregnancy. So 100 milligray is a large quantity, a large number. Typically, when I talk to our residents, I used 100 milligray as like equivalent to like having 10 CTs all at one time during the first trimester, which can accumulate more than 100 milligray or 100 millisievert dose to the fetus. What is the risk for the fetus? The excess risk for childhood cancer is estimated as 0.06% per 10 millisievert. 10 millisievert is typically like abdominal and pelvic CT, let's say. So a typical abdominal pelvic CT done at the higher end, 10 millisievert ballpark number, each can have a possibility of increasing the risk of 0.06%. This is a very small quantity. The other one is like the somatic effects such as body size and mental retardation. The threshold dose is anywhere between 50 to 100 milligray. That's considered as a threshold dose for any type of somatic effect such as the body size and mental retardation, that decreasing head size and so forth. Here's a nice chart published recently in Radiographics which tells us the way we can use this information to explain to the patient or to the physician. Here is given a chart telling the probability of birth with no malformation or no childhood cancer. Basically it tells us like if there is no exposure, there is no radiation exposure, the probability for no malformation is 96%. Right off the back, there is some 4% possibility for some malformation in any regular pregnancy. For no childhood cancer is about 99.93. How does this increases with exposure to radiation? If we go down the list, if it is a 10 milligray of exposure to the concept, to the fetus, that increases the childhood cancer risk will increase from 99.93% to 99.84%. It means like the increase is only about less than 1%. It's about 0.1%. This information is very helpful for us when we are explaining to the physicians or the residents to show them in general the radiation effect to the fetus is quite small compared to all other complications in the regular pregnancy. And that information is very critical because when a patient finds out she's pregnant and she's exposed to radiation, the psychological effect far outweighs any of the radiation risk we see, because that's the largest component, and we have seen many times they're terminating the pregnancy even when they had a head CT or a head X-ray, radiographic of the head. We have seen that instances. So even in cases of dose of 100 milligray to the concept, even then the increase in the childhood cancer will only increase about less than 1%. But these numbers are good for us to understand, but it's very difficult. If we show this table to the patient, it doesn't make any difference for them. However, how we can use this information to explain to the patient makes a lot of difference. So, two categories. Standard radiographic and fetal exposure. The dose to the fetus depends on a number of factors, like most of you know. It depends on the tube voltage, the tube current, and the scan time, and also depends on the fetus distance from skin surface. Again, the inverse square law works to the benefit of the fetal exposure. The other component which also impacts are the filters, collimations, and so forth. I would highly recommend this particular book by Dr. Wagner and Lester and Saldana, which has a detailed description of the various effects of radiation exposure, the effects on the pregnancy and the fetal exposure during pregnancy. And this is a good guidebook if you guys are often asked to do this fetal dosimetry. This is a good reference book to have your bookstop. It discusses various scenarios, and a lot of these diagrams are taken from that particular textbook. So, in the chest radiograph, and what is the effect on the fetal exposure when there is a chest radiograph happen? In this case, the fetus is not directly in the X-ray beam. Therefore, there are very few scatter radiation reaches to the fetus. And that's purely by internal scatter. The fetus dose may be as small as 10 microgray or 1 millirad. Therefore, this is one thing which I normally use when I get the question about from the emergency room physicians, what they should do about the patient when they know that the patient is pregnant, they want to take a radiograph or X-ray procedure. First question I'm going to ask is like, what is the primary area of the X-ray beam going to fall on? If the radiation dose to the fetus when it is not in the X-ray beam, means the primary beam is not directly focusing on the fetus. In that case, we can conveniently assume in conventional diagnostic procedure, the radiation to the fetus is almost about 1 millirad or 10 microgray, purely because of the internal scatter, and that's almost same as background radiation dose. In fluoroscopy and CT procedure, again, the internal scatter can go up to 5 microgray or 5 millirad. In abdominal and conception radiation, in this case, the fetus is directly in the X-ray beam. Again, here, when the fetus is directly in the X-ray beam, we conservatively can estimate the surface dose to be the fetal dose. That's fine. But in reality, the X-ray intensity reaching the conception is usually less than 50% of that entering the patient. Therefore, the fetal dose may be as much as 10 milligray or 1 rad. The rule of thumb is, for fluoroscopy and radiography, the fetal dose can be conservatively estimated as 0.15 times the entrance skin dose. It's about 15% of the entrance skin dose. This applies for the fluoroscopy and radiography when the beam is when the fetus is directly in the path of the primary beam. So, the rule of thumb is, if in cases where the fetus is not directly in the beam, any particular type of procedure, is it whether X-ray, fluoroscopy, or CT, is deemed quite safe because the internal scatter reaching the fetus is quite small. So that's one first thing which I normally ask our physician when they ask this question about the patient being pregnant and doing the procedure. If the procedure does not involve the fetus directly in the beam, I would comfortably make a statement telling that they should not worry about the radiation dose to the fetus, because the radiation dose to the fetus is minuscule. It's only because of the internal scatter. If the procedure involves directly the path of the beam, that's when we try to discuss about various steps to take to minimize the radiation dose to the fetus. Again, in fluoroscopy and radiography, the fetal dose is approximately 15% of the entrance dose when the beam is directly in the path of the beam. So, for estimating the fetal dose for CT studies, there are a number of papers, publications have discussed these things. I still go back to one of the publications back in 1990, which quite useful to estimate the fetal dose estimation. The way it's been done is like the normal fetal dose ratio is given as the dose at the depth divided by the CTDI. And here, the INFDR is basically standard, like integral normalized fetal dose ratios are defined as the normal dose ratio for different slices, the central slice and the adjacent slice and all the slices adjacent. If you add up together, we can come up with a fetal dose estimation. And this particular publication describes in detail about this, how we can do the fetal dose estimation. Again, all our speakers' handouts will be put on the website for later, for any of these references, to search for the references. The other way we can quickly do is like using, we can also do fetal dose estimation with most of us which are familiar with the impact dose calculator. In this case, the fetal dose is reasonably estimated to be equivalent to the dose received by the uterus. Again, these are reasonable estimation. So, if you do a calculation and you get a uterus dose displayed on this particular calculator, you can use that as the fetal dose. For example, here in this particular diagram, here's the chest CT. The fetal dose estimate comes out to about 0.03 milligray for the chest CT. It's about 0.3 millirads. So, again, using this beam of 120 kVp, 200 MAS, 10 millimeter collimation, which is a typical protocol technique. So that's the estimation. The effective dose estimation, if you're done using an impact dose calculator for abdominal and pelvic CT, in that case, the fetal dose is reasonably estimated to be equivalent to the dose received by uterus, which is about, like in this case, about 28 milligray for abdominal pelvic CT. So there are multiple ways. Either you can use the more detailed calculation method published in the Dr. Felmy's paper in AJR, which goes into the details of how we can calculate the fetal dose by adding up the normalized dose ratios from different slices. Or for a quick estimation, you can use this calculator. If we are using these things for CT estimation, the uterus dose can be reasonably used as a fetal dose exposure. And this has also we are seeing this being used in the literature because this is one of the latest publication which came out this year, where the fetal doses, radiation dose, and the trend in body imaging during pregnancy. Here is shown in this graph is basically the CT exams of pregnant patients per year normalized to 1,000 deliveries. As you can see here, the increased number of CT exams are growing as demonstrated by the other data. And here is the CT exams of the pregnant patient per year is also slightly going up because more and more complex patients comes into the clinic and more CTs are also done. In this particular publication, these authors have used the fetal radiation dose estimated based on the impact dose calculator, and they have used the dose to the uterus, which is considered equivalent to the fetal dose, which is reasonable. And in this particular study, the mean radiation dose to the fetus was about 25 milligray. Again, the table indicates even with the dose of more than 100 milligray, the chances for childhood cancer increases by less than 1%. So that particular information is the background to know. There are other methods which is more sophisticated and with the indication of calculating more accurately. This is another publication came in Radiology, which estimate the fetal dose estimated based on the maternal perimeter. Basically, if here is a case where you can see a full-blown fetus in the CT image, if you calculate the perimeter, if you measure the perimeter of this particular abdominal area using this particular table, basically based on the perimeter of the mother, the normalized fetal dose is given per 100 MAS, which is again a very useful information. It's about 10.8 milligray per 100 MAS. So for a protocol of 200 MAS of 120 abdominal pelvic CT, this again reference back to this impact calculator about 20 milligray or 25 milligray fetal dose exposure. So these are three different scenarios which we can use for calculating the fetal dose estimation when the beam is primary beam hitting the fetus. As I said, if the radiography, fluoroscopy, or CT, or any one of these procedures, if the primary beam is not focused on the abdomen and pelvic area, that the fetal exposure is almost insignificant, is almost equal to background radiation purely because of the internal scatter. And the calculation appears only where a more detailed calculation is required when the protocol involves the fetus directly in the path of the beam. The conception dose based on, this is another table basically indicating what is the fetal dose based on the different type of radiation exposures. For a conventional radiography, this particular publication provides about 2 milligray per exposure. For CT, it's about 5 milligray per slice. Fluoroscopy is about 10 milligray per minute when the conception is directly in the path of the primary beam. This particular slide is a busy slide, but I just want to draw your attention for this particular publication by Cynthia and group in Radiographics in 2007, which basically estimated the conception dose from various medical X-ray imaging procedure, which is quite helpful for if you are trying to answer a phone call from your referral physician about some fetal dose estimation for a quick estimation. And this provides a variety of these procedures from single CT and from nuclear medicine procedures for a radiographic and fluoroscopy exam, basically providing all this typical fetal dose for various of these procedures. Here are some of the tips which can be followed for fetus directly in the X-ray beam, where the estimated X-ray dose is less than 10 milligray, such as in X-ray, like in radiography or in fluoroscopy. These are recommendations we discuss with our residents, our physician. Radiologists should discuss benefits and risk of the procedure with their referring physician, and possibly as normally any particular X-ray procedure, the other imaging techniques should be considered if possible. And if the X-ray exam is necessary, there should be some type of a recommended document is needed in medical record. The radiologist explain procedure to patient and assure that the risk to the fetus is small, and the radiation dose should be kept as minimal as possible. If the fetus is directly in the X-ray beam and the estimated dose is between 10 and 50 milligray, that's about 1 to 5 rad, the radiologist and referring physician should discuss other imaging option. If X-ray exam is necessary, the patient should be involved in decision to proceed with the examination. That's correct. So that the patient is also part of the discussion about this involvement of the risk and benefit of this particular procedure. Patient should be informed of the risk and benefits and may be required to sign a consent form. Again, we don't have a uniform consent form national across the nation. So certain institutions have this informed consent and certain institutions may not, but this is kind of the recommended suggestion. And there need to be some type of a document in medical records of this particular discussions went through and so forth. If the fetus is directly in the X-ray beam and the estimated dose is greater than 50 millirad, then there should be a trigger point for calculating a formal calculation. The dose should be considered by a radiation physicist or equally qualified individual. Patients should be counseled about the risk to the fetus and document the need in medical record has to be done. Here's again another table basically describing the fetal effects from low-level radiation exposure. This particular table is again taken back from this Dr. Wagner's book, which basically describes, reflecting back to the original curves or graphs I showed about the fetal radiation exposure, basically discussing what are the different effects, for example, prenatal death, what is the most sensitive part of the pregnancy of the conception, and what is the threshold required, and what are the comments. So this particular table I find it quite helpful when I'm trying to understand some of these fetal dose exposures effect. So the key points are the threshold dose to recommend for therapeutic abortion, for considering therapeutic abortion is greater than 100 milligray to the fetus during the first 6 weeks of the pregnancy. The benefits of the medical imaging procedure should be weighed as part of the risk assessment and counseling patients who found to be pregnant. A lot of the time it's beneficial for physicists to talk directly to the patient, explaining this, both the risk and the benefit ratio, thereby avoiding some of the unnecessary psychological stress to the patient. When the fetus is outside the primary path, the radiation dose exposure is generally negligible. So we as a physicist can be very comfortable making a statement that if the fetus is not directly in the beam, the radiation exposure to the fetus is insignificant. It's very small, and the imaging procedure should not be stopped or anything. When the beam is directly in the path, when the fetus is directly in the path of the beam, careful analysis is required, and then all possible optimal techniques should be adopted. For example, a lot of the time when the pregnant patient is brought in to do some coronary angiography procedure or cath procedure, the question I often get is like, what should we do about this patient? And my suggestion is try to minimize the exposure where the physician enters the catheter through the femoral artery to insert the catheter all the way to the heart area. If they can minimize the exposure during the fetal area, that's a few seconds of exposure. The radiation exposure to the fetus is quite minimal. So these are some of the steps. If we discuss with our physician, they feel more comfortable in doing this patient. At the same time, as long as the benefit of the particular procedure far outweighs the risk, then the fetal exposure for most imaging procedure is quite low. In conclusion, radiography, fluoroscopy, and CT examination in areas of body other than abdominal and pelvic delivers minimal radiation dose to the fetus. Fetal radiation doses from radiography, fluoroscopy, and CT examination of abdominal and pelvic and from nuclear medicine rarely exceeds 25 milligray. Based on the risk data from human in vitro exposure, the absolute risk of fetal effects are small at conceptual doses of 100 milligray and negligible at doses less than 50 milligray. These are useful, some of the references which I highly recommend for us to use, which discuss quite detail about these various aspects of fetal radiation dose effects and so forth. So here are the questions. What is the typical dose considered as threshold prior to recommending to therapeutic abortion? 50 milligray, 10 milligray, 1 milligray, 100 milligray, or 5 milligray? Let me start the clock. I'm glad. 95% had chosen 100 milligray, and that's the correct answer. And here's the reference. It's been listed in Eric Hall's book, Radiology for the Radiobiology for the Radiologist. Again, this is another highly recommended book with for medical physicists in terms of radiation biology understanding by Eric Hall. They have a 5th edition now. The second question: what is the radiation dose to the fetus when the primary radiograph region is outside the pelvic region? Number 1, less than 10 milligray, less than 0.01 milligray, less than 1 milligray, less than 0.1 milligray, and approximately 100 milligray. Let me clock them. Not bad. At the end of 2 hours, still we are getting the right answer. The correct answer is number 2, 0.01 milligray, purely because of the internal scatter. And again, this information can be found in this reference. The final question: what is the most probable effect due to radiation during pre-implantation or during first trimester? 1, growth retardation, congenital malformation, severe mental retardation and reduction of IQ, leukemia. The 5th choice is prenatal or embryonic death. The answer is correct. Prenatal or embryonic death. That's the high probability. Again, I should have changed this. I should have worded the question even more accurately. Most probable effect. That's the high probability for this causing prenatal or embryonic death. So, thank you very much. And if you have any questions, we are here to